This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast.
All right. Lindsey, do you want to introduce yourself real quick? And then we can, Cody, you can introduce yourself, and then we'll go from there.
Sure. I am Lindsey Ewing. I'm a critical care flight paramedic in Virginia and paramedic educator on most of the other days of the week.
Nice. Thanks for coming back on the show, Cody.
Hey, what's up, everybody? I'm Cody. I'm a flight medic here in Maryland, and like Lindsey, I do education when I'm not flying, and just happy to be here.
Sweet. Thanks both of you for joining the show again. Cody, I think I mentioned previously that you were one of our only explicit tagged episodes, so I'm sure we'll be able to pull that off again. Lindsey, so I wanted to jump right into it. Talk about the post that we are going to be talking about today, kind of the origin of it, and then we'll dive right in.
Yeah, I think one of the most important things about our job in pre-hospital medicine is the ability to communicate successfully and appropriately with our patients. And a lot of times in the classroom, especially at the BLS level, we are given these templates of like questions that we should be asking and how we should be asking them. And in the real world, that doesn't cut it most of the time for our patients. So this post was just a discussion about a few different like nuances and things that we can consider when asking questions to perhaps get a more accurate answer from our patients. That being said, the caveat is that like nothing is ever black and white. This is all just like things to consider, right? Like every patient is different. Every situation is different. There is not a right or a wrong every time. But there's definitely some ways that we can talk to patients differently, ask questions differently to set ourselves and them up for success.
Cool. Just initial thoughts from Ken or Josh?
No, I think this is a really important discussion because the way we approach our patients, the way we talk about things, then influences everything that happens afterwards, especially that initial interaction. We talked about it on our last episode with Lindsey about how negative it can be to wake somebody up with Narcan and be like, "What'd you take?" Right? I think that's a perfect example of this, and we just need to be very mindful when we interact with patients that whatever we say and do is going to change how everything follows. So there are key phrases that we should use and key phrases we should avoid.
And Lindsey, you posted today about just how you say certain things and how sample it takes us into this realm of saying things in a very specific manner that doesn't elicit the right answers. And we need to develop ways, and we all here develop these ways over many years through trial and error many times of asking the question in the wrong way and maybe not getting the answer we want. And that can change how we're on scene with the patient and how the patient wants to interact with us. Because if we say it in too much of an academic way, maybe the patient may not want to interact with us because they're not understanding what we're saying, or they just think we're on a different level with them. And I think the points that are going to be brought up today are some really good ones because it takes certain situations and scenarios and gives us a kind of framework of what we need to say and how we need to handle it.
Cool. Cody, what you got? Anything before we get started?
I used to say you're either doing an assessment or having a conversation, and having a conversation with the patient is going to get you a whole lot further as far as building rapport. And therefore, they're more willing to give you the information that you're trying to get out of them versus interviewing them to complete your assessment. And it gets really cold and mechanical. And you may, to your point, ask right question the wrong way and still get the wrong information, and then make good decisions based on bad information.
Yeah, before we get like actually into the specific things, what comes to mind for me, kind of based off of what Josh said, was nothing pisses me off more than an arrogant medical director that wants to sound smarter than they are by talking with big words, right? And that just pisses me off. Or like educators that want to talk above their students on purpose because like deep inside they have this sort of ego thing that they got to work through. So no, I really like what you guys are mentioning. And Lindsey, you want to get started with the first little tidbit you had?
Yeah, I think this is one of the most basic common ones. Is we know the P in sample is past medical history, right? And so how often do we all hear students or new providers ask the patient, do you have any medical history? But if we take a step back outside of a clinical role, we have to recognize that that sounds really foreign. Like medical history, what does that mean? Like, does that mean we care about when they had the flu 20 years ago, when they had their appendix out 15 years ago? It just is not clear. So I like to replace that with, do you have any medical problems? Or depending on the patient and the vibe, do you have any medical conditions, right? Have you been diagnosed with any specific medical conditions? And then we can go into all sorts of ways of how we can elaborate on that, right? Like, what medications do you take every day? What are you prescribed? What are you prescribed that you're not taking? What do you take over the counter? Because we've all had the patient that says, no, I don't have any medical history, but has a Walmart bag filled to the brim of multiple different prescription bottles, right? So if we can ask them what medical conditions they have, what kind of interactions they've had with doctors or specialists, and what medications they take or should be taking, usually some combination of that can create at least a good framework of what their true medical history actually is.
Yeah, I remember reading this and seeing this and being like, when you say medical problems do you have? And I still even think it now today, like when I say that, am I offending them? Even though I know this is going to get a much better answer because I'm saying problems. Like, what problems do you have? Some people might not want to hear that, but it elicits such a better answer than history, because people don't look at what they have that's going on with them as history. It's just their current life, and it's not something in the past. It's something now, and it's a problem now.
So a lot of people
things to like change your thought on how you're saying things, but it actually is a better question.
Several people actually brought that up in the comments about, because in the initial post I had said, do you have any medical problems? And several people were like, that's offensive. It should be switched with conditions. And I was like, meh, like, I think this depends, right? How many times have we had an elderly patient who's like, well, I got problems with my hips, and I got problems with my eyes, and I got problems with my heart. Like, they're not going to be offended if we ask them what other medical problems they have. That being said, we may have a younger patient that we may be dealing with psychiatric history. I do understand how phrasing it as, do you have any medical conditions, may be a little more sensitive to that patient rather than framing it as a problem. So again, I think when it comes to that type of word choice, is just reading the room.
I think it's really important that you phrase it in either one of those ways. I've always said problems. I can see where that might be offensive to somebody, but one thing I have run into on multiple occasions is the patient who you say, do you have any medical history? And they're like, no. And they're like, do you take any medications? Well, yeah, I take, 3 antihypertensives. Well, do you have high blood pressure? No, I don't have that problem because I'm on the medication for it. It's fine. So I think that does help circumvent that a little bit.
It's a good point, Ken, because you could change that question into a two-parter, right? Instead of, do you have any medical problems or history, which is an us term, you can say, one, do you see a doctor? Yes or no. And then what do you see your doctor for? What are you guys talking about? What are you guys working on? And that gets you, I think, can get you a little bit further than yes, no answers, and definitely get over those hurdles that you're talking about, Ken.
Yeah, and I think when we're talking about the kind of the nuances of asking these different types of questions, I think we often come up with these like two-part ones. And I think, Cody, it just brings up a really good talking point that we have to make sure that we are only asking one question at a time. So obviously we all have multiple part questions we want to ask. But if we say, do you see a doctor? And if so, what do you see them for? You're not going to get the complete answer. It has to be one question at a time, pause, then ask the next part of the question.
Yeah, I think we've all run into the when they bring up their doctors and they're trying to sit there, remember the name and what they see them for and when they last saw them. And now you're asking this person that, say, we got the person that's got hypertension, diabetes, they're a COPD or a CHFer, they've got lymphedema, they've got neuropathy issues. They're seeing a multitude of docs, and so they're just going to, and that once again, that patient that Lindsey alluded to, that just opens the door to, well, I got this going on, I got this going on, I got hip surgery in 1950, I got this. Now you're sitting on scene, and almost as rude to interrupt them, but you also have to get to the end point of how am I going to take care of this patient.
All good points. All good points. You ready for the next one?
Yeah, I think the second one is quick, almost like a subcategory of this, but along the lines of using terminology that makes sense to the patient, not just to us. The R in OPQRST, as we all remember from EMT school, is radiation, right? So we all hear, again, newer providers or students say, oh, does your pain radiate anywhere? And again, if we step back out of a clinical role, that sounds really freaking weird. Like, what do you mean? Does it radiate anywhere? Like, is it giving off heat? I don't know what you're talking about. So just simplifying this and saying, okay, so I know you have pain in your chest. Does it feel like that chest pain goes anywhere? Does it feel like it just stays right there? I know you said you have pain in your chest. Do you have pain anywhere else? Just simply rephrasing that to avoid those terms that are probably going to confuse a good chunk of our patients and not get us an accurate answer.
I like that. What strategies do you guys use for just getting a general sense of pain?
So I find also, like, in that realm, the asking the question of how it feels. Like, I know we're supposed to ask open-ended questions, but when you ask a patient, how does this pain feel? I swear, anecdotally, 70% of the time I get the, what are you talking about? Like, what do you mean? What does this feel like? And then you got to kind of probe a little with a couple, like, well, is it stabbing like this? Is it someone sitting on your chest? Is it dull? Is it sharp? Is it whatever terminology you want to use? And then we're getting into the leading. And so it's kind of weird. Like, I always find issues getting an answer from that, that you kind of have to lead a little bit to give them ideas of words we're looking for. Because, sometimes they just get the blank stare. With the radiation, where does the pain go? Simply, you got the pain right here. Does it go anywhere else? Just like you said in the post, the radiation, you're not going to get a good answer from that, I think.
Yeah, and this is where, this is so not black and white, and it's so personal preference, because it's funny that you said you like to suggest words to help them out. I'm the opposite, and I'll kind of skip ahead because this is one of the talking points too, and so maybe this is where things get a little controversial here. I know, right? He's not here to stir the pot. I don't love giving words. So if someone is telling me that they have chest pain, I will ask, how would you describe the pain? If you had to give me one word to describe it, what would you say? I feel that if I start offering them words, they just become like yes men, yes, like they want to give you an answer. They know you're looking for an answer, and maybe it's accurate, maybe it's not, but I don't usually feel confident. If I have to suggest the word, I don't really feel that it's super accurate. And I also don't care enough to get an inaccurate answer. And what I mean by that is that if a patient can't describe their pain, I would rather document patient unable to describe pain than document something that I feel like they're saying yes to just to appease me and answer the question. But again, that's just a stylistic thing. I don't think there's a right or wrong answer. It's just preference and probably based on the situation.
Yeah, pay attention to their body language. I think it's important. Even though we're asking questions, when you're saying, oh, my chest hurts, and they're moving it back and forth, where do you think it's probably radiating to? It's probably radiating to the arm. Or if they're going, man, my chest is killing me, it's probably radiating up and down. It's probably going up into their jaw and stuff. So other cues to pick up on to get the information that you want.
Ken, do you ever plant words, or how do you approach it?
Yeah, so I do very similar to what Josh does. I'll ask the person, can you describe your pain for me? Or I use the word discomfort. I don't use the word pain. Can you describe your discomfort to me? And if they can't, then I do offer suggestions like, is it sharp, dull, pressure, heavy, numb, tingling? Like, how would you describe it? And I can see where that could be problematic. But at the same time, I've also, I don't know, I've usually gotten an answer, but am I leading them into that answer? Maybe. I'd like to think I'm offering diverse enough words that it's inspiring some sort of thinking process in the patient, but maybe it's not. And as far as the radiation thing goes, I usually just ask if the pain moves anywhere. Does it move from your chest down your arm? Does it move into your jaw? Does it move anywhere? Kind of deal. I don't usually offer suggestions with that one. That's just a yes or no kind of question to me.
Yeah, I usually don't give specific descriptors because I think that's where we can get into the leading territory. Like, for whatever reason, like I just had like a STEMI a few weeks ago where I asked the guy, does it feel like an elephant sitting on your chest, right? Because he was describing this like pressure, right? So I usually give him, I mean, it might sound silly, but I usually give descriptors like that instead of specific maybe adjectives it would be the better word. So that works for me. I can't say I don't think I've ever led someone into answering, because it's usually not. It's a big thing that I like that Lindsey said was you got to read your patient and you got to read their body language, or maybe Cody said that too, because if their affect is completely off, they seem like they're intimidated by you, then I probably wouldn't be that forthcoming with suggestions and would probably document as such. But if they look like they're truly pondering and trying to find the words, then I might throw in, situational descriptors like that. But all good points. All good points. Number 3 is the big one. So I think, right, from what we were talking about. So Lindsey, you want to go ahead with number 3?
Yeah, number 3 is regarding death notifications. And before we get into this, I hope you guys don't mind. I want to plug Emergency Resilience on Instagram. I love her so much. She's a super cool human. She's a fabulous educator in a really unique space that I feel like we don't get a lot of education on. So if you guys don't already follow her, make sure you go check her out. She has a death notification course that's virtual that is like fabulous content. So you guys can check that out as well. And I know she definitely totally supports this point, which is that when we are doing death notifications, we have to use the word dead or died. And I would say this is the one on this list that is probably the most black and white. I will say there's still gray area when we respond to a hospice patient or someone where we read the room and it is obvious that the family knows what has happened. This has been an expected death. They already are making it clear they know the patient is dead, or they're asking you, is he gone, or whatever. Those instances may be slightly different. But in the situations that we see frequently where it's an unexpected death, or a traumatic death in any way, shape, or form, we have to use the word dead and died, because any of the other euphemisms like gone, passed away, whatever, those leave room for confusion. And there's always some pushback on this from folks that say, well, that's not confusing. Like, it's clear, like they know what I mean. No, when someone is grieving, when someone is traumatized, they are confused, they are hysterical, they are upset, they're processing everything that's going on. Those things are not common sense. Those euphemisms are not clear. The only way for us to make it unmistakably clear for these patients is to use the words dead and died. And I know that's uncomfortable for us, but for us to avoid those words for our own comfort, all we're doing is making things more difficult for the family. So we have to be able to suck it up and figure out how to do this in the best, most professional way possible by using those words. We can absolutely still be compassionate while using the words dead and died. And we can talk about all of that. But anything less than that is simply not clear and not direct enough in the middle of a traumatic situation.
Like Moose led this off, this is it is the biggest point on this list. It is the most important on this list, honestly. Emergency Resilience, she does some great posts on this. Hopefully have her on the show soon. But Maryland took it upon themselves, Moose, how many? Probably 6-7 years ago. Maryland created a course.
Talking about Break It To Me Gently.
Yeah, Break It To Me Gently, on how to talk to family. And it very, very blatantly states to use the words dead or died. Not to use passed away, is gone, is no longer with us, or any of these euphemisms of death. And, you know, if you look at it, and many people have posted on this, the use of these words helps with the grieving process. Like, it helps start it. It helps give finite things to the grieving portion of this call, that there's no thought of, well, things could change, passed on, or they're not with us. Oh, so you meant they left the scene. They're not here anymore. You know, things like that. And there's some other things coming from this that we're finding help with the grieving process. You know, having the patient's family in the room during the resuscitation, things like that. I don't encounter this a whole lot in my current, assignment, because I'm not the officer. I'm the one usually running the cardiac arrest. Luckily, our officers and our duty officers handle these notifications for us pretty well because of the way we run cardiac arrests. But when it does, you know, even me as the paramedic, and in many portions of this country, the paramedic is the one that's going to be telling the family this. It's not an officer. It's not a police officer. It's the paramedic. It's the person that just got their card. It's the person that's had their card for 20 years. They're going to be the one telling the family. So there's a very specific, not specific, but very, defined, or that's saying specific way of doing this to make sure that it's done correctly. It's a very important portion of the call. So
I think it's one of the opportunities we have to honestly make the most difference in families' lives, because they will remember this moment forever. And we also receive the least amount of training on it, which is super unfortunate. So, I mean, it comes down to the small things, like you said, you know, letting the family watch the resuscitation if they want to, having someone update them along the way as far as what's going on, letting them know that you're going to call the code before you actually do it if there's no changes, being able to explain those things in simple form, taking gloves off, sitting down with the patient in the next room, asking if there's anyone you can call, giving space for questions, being okay with silence. Like, there is so much we could talk about with this. This should be, hopefully you do get Alex on emergency resilience and you can have like a whole in-depth episode about this, because it's so important. And I mean, patients truly will remember this forever, whether we do it correctly or we do it incorrectly. And so we really owe it to patients and their families to do it to the best of our abilities.
Yeah, I think that it is a really important topic that could and should be its own episode. It's something that I do almost daily at work. Unfortunately, as an EMS officer, I'm constantly giving death notifications. Excuse me. I think that one of the most important things is that you set the expectation early in the code. And the way I do that, when I initially approach the family, I go in, I make sure the cardiac arrest is being run appropriately. Then I immediately go to the family and I say, hey, this is what's going on with your loved one. And the reality of the situation is they probably will not survive. Most people die from what your loved one is experiencing right now. And at that point, the expectation is set at the baseline that this is probably going to result in death. Now, if it doesn't, that's wonderful, right? That's what we want. We want ROSC. We want neurologically intact walking out of the hospital. That's great. But the reality of the situation is that's not what happens in most of these cardiac arrests. And if you can give the family half an hour to start processing that, or however long your protocol calls for you to work these situations, I think that's really vital. And you work that word dead in there early, or death, or do not survive, or some very explicit variation of that term that, like you said, not a euphemism, not going to make it, not, anything like that. I think that's critical to set that expectation early.
I don't know what you guys think about this, but I will also do a similar process in the case of ROSC in a patient that I know with pretty good reason is not going to have a great outcome. The 80-year-old with comorbidities that we had to work, and then we got ROSC on after, a 30-minute downtime. We know how this is going to go, right? And so the last thing I want to do is, after having these conversations, is give the family false hope and say, oh, we have a heartbeat back, we have a pulse back, we're going to the hospital now, and them think that their loved one is going to be back to normal next week. So I am generally explicitly clear with those families, and will say, I don't know what the status of your loved one's brain is at this point, but they went a long time without blood flow. They went a long time without oxygen. And then there's a good chance that there could be some very severe, irreversible brain damage. So I want you all to be prepared for that likelihood, or something like that, right? And, make it clear that they're going to have to work with the physicians to figure out the intricacies. But, we don't want those patients thinking that they're going to be eating dinner with their loved one next week.
Yeah,
I do a very similar thing.
For the listeners out there to think about this, if you don't look at the data behind all this, I'll just give you some numbers. The agency I worked for last year, we had I think a 31 or 32% ROSC rate. Out of that, we had 5.4% that walked out of the hospital. So make sure, and this is speaking to my agency. Those are the numbers. Whatever your agency is working with, whatever numbers you have, you need to prepare the family that, hey, this is still a very serious issue. This is not oh, everything's fine. This is Hollywood. Mom, dad, grandma, grandpa is going to walk out of the hospital. No problem. I think Lindsey talked about it, and Ken talked to it too, as well as constantly briefing the family during, going back and saying, okay, this is what's happening now. This is what's going on. When things change, when ROSC happens, okay, this is going to happen. It's going to get a little busy. Things are going to happen. It's busy but slow format. It's still a long, hard road for your family member to come out the other side, and death could still very, very much be a possibility. Lindsey, you started off with saying, this is a tough thing for some people to understand how to do. And I want to caution the new providers that may be listening. There's awkward conversations that we're going to have, not just about death in this profession. I feel like there's 3 really awkward conversations we have: death, wanting to kill yourself, and then those really tough 3 questions you got to ask every female that has abdominal pain, regardless of once they're in childbearing age. And that's just the start of the awkward conversations. There's a lot of awkward things that we need to understand how to handle properly. And if you need to get the training to understand how to talk about these things, because it's important to the job. So just, to the new providers out there, this is just the beginning of awkward conversations with family members and patients.
That's so true. I kind of put the other awkward conversations in a bit of a different category than this one, because, I'll tell students the vagina conversations are only as awkward as you make them. Just own the vagina. Do you have any discharge? Does it smell? When was your last period? Just own it. They have herpes. Great. Talk about herpes. You've had herpes for the last 3 years. The more awkward we are, the more awkward they feel. If you just own the awkward, you own the herpes, whatever it is, then they don't feel as awkward. So that's my philosophy.
Yeah. The big thing I would say is what we're not saying is that it's not okay to feel awkward, right? We're all human beings, and let's just level set here. It's not a normal thing to tell another human being that you didn't know half an hour ago that their kid is dead, right? It's not a normal thing. It's not a normal thing to have to tell someone all the invasive stuff they just witnessed. Now their person might have a pulse, but all the other things that their person now has to deal with, right? It's not a normal thing. So on top of that, especially for newer folks, but anyone, maybe folks that are seasoned but have functioned in a toxic work environment where mental health isn't supported. The big thing I want to stress is it's okay to feel awkward about any of these conversations, but it's also your responsibility to try to find the resources that you need to help process that. I remember, not process it, but get the skills, right, that you need to be able to deliver the message better. And I think emergency resilience is one of those, pages that provides those resources. I remember a couple years ago, more than a couple years, it was pre-COVID. So it must have been 2018. It was like right before Christmas. It was like a week before Christmas. I responded, and actually I wasn't working. I responded because at one point I was like an EMS administrator for where I live. And I ended up having to tell a gentleman that his significant other of like 50 years had passed away a week before before Christmas, right? And I remember my voice cracking, because the cop shot me a look, and I was like, oh, oops, I messed up there. And I kind of felt pretty bad about it for a little bit. But the fact of the matter is it's completely human to also feel emotion, right? I think we're pretty good at compartmentalizing because we have to. I'm not saying that you should be necessarily crying with your patient, but it's okay to show emotion. It's not a marker of how good of or bad of a provider you are. You're just human, right? So I just want to stress that fact. Regarding your guys' previous thing about actively checking in with patients' families, I think that is so important. I ran an arrest again a couple weeks ago. I couldn't tell you the exact date where BLS crew arrived on scene. It came out as a fall, and the BLS crew and the engine company found the patient in full arrest. They literally did everything they needed to, right? Clinically, they did a great job. They spoke to the family member that found them. So the first thing I did was I showed up. I started doing some, all I really needed to do was give epi because they had kind of done everything else after checking the rhythm. And then I went and talked to the family member and then explained to him, hey, like your family member is very sick, right? And I like what you guys said about setting the standard early, that a lot of people don't make it out of this. Once we got Rosk, I told him, I said, sir, your family member is still very sick. And I used the words critically ill after that. And I said, we are going to go to the hospital. And I told him where we were going. And I said, I'm going to let the physicians know that you are on your way, and they will be able to explain to you the next steps. This kind of leads to your next question too. I ask this of every single patient. I said, do you have any questions for me? Right? I always do that. And I stay quiet at that point. It might take them a little bit, but you generally, if they don't have questions for you, they will at least thank you and appreciate your efforts, right? So I don't want to take away anything from this topic though. So I'll give it back to you guys if anyone has any comments before we go on to the question thing.
The only thing I'll add is that if the family or a bystander there initiated efforts prior to our arrival, super important for us to tell them that they did a great job. Honestly, even if they didn't do a great job, like if they were there with good intent, like they were trying their best, we can save that person a great deal of stress and grief after the fact if we can relieve them of any sense of like guilt or responsibility and tell them that they did the best thing they could have done for that patient. We appreciate them so much. If the patient didn't make it, that make sure we let them know this patient was so sick that there was nothing anyone could do for them, but that person gave them the best chance possible.
No, I like that a lot. Nothing else on this topic before we move on?
No, but you got real serious there, Mustafa. So I think maybe you should edit out the vagina and herpes spiel
Oh
because
no, I like it. I like it. We're gonna keep it, and we're gonna keep this too.
you took
I'm
me back
owning
to
it.
like dead babies immediately, and I was like, oh my god.
Lindsay said the whole thing about owning the herpes, and Cody and I lost it. The two of you were as stone faced as if like you were looking at death in the face right now. I was like, I'm looking, I'm like, oh, should I be laughing?
Yeah.
Did I
No,
open the door to
that
this
was like a
conversation you didn't have?
We're gonna keep all of this. This is gonna be
yeah.
perfect. I'm
Great.
not editing shit.
Well,
That was like a fart in church. You're not holding that in. You're gonna lose it.
okay. Anyway,
But
moving on.
that's kind of the duality of EMS, right? One minute it's all fun and games, the next minute it is dead babies. You know, it's like a
That
perfect
is
example
true.
of what
Yes.
this job is.
That
If
is the
If
most.
only you guys knew where my brain goes and how quickly it jumps from a million different things. Honestly, I heard you say the comment, but I don't even know where my brain was, right? So like, yeah, it probably just didn't connect. But yeah. Back to the topics. Where are we at? Oh yeah. Number 4.
We're talking about asking people if they have questions. So this is a really small modification, and it may be perceived as like it really doesn't matter. And in a lot of situations, maybe it doesn't. But I think that if we were to ask someone, do you have any questions? And if we could go back in time and ask the exact same person in the exact same situation, what questions do you have instead? I think the latter will often yield more results, because the first one, do you have any questions, is a yes or no question. And people like to appease us or not inconvenience us. And so it's just easiest to say no. But if we're essentially not giving them the option to just say no and asking, what questions do you have, whether it's in the context of a death notification or any other routine call, what questions do you have, gives them a bit more leeway, I think, to be more open with whatever questions and concerns they may have.
I think it's important to make the patient feel empowered, or the family to feel empowered to be a part of the process. And by phrasing it in that way, it's that person first language where it allows the person to feel like they have some ownership over the situation and say, okay, I do have some questions. Yeah, thank you.
Josh,
Yeah.
that right there has to be a reel. What Ken just said has to be a reel.
Mark, got it.
Yes.
Okay.
I made a reel. I've been
Bro,
wanting
you're
to be
gonna
a reel
so
since we started
famous
reels.
on all the interwebs. You're gonna be so famous.
I think this is really important because there's a lot that we do that sometimes we're maybe not the greatest at talking about what we're doing in the moment. So we just kind of go on autopilot, especially for those of us that have been doing this for a while. Okay, this is a STEMI. Okay, I know I got to get a line, I got to get aspirin, I got to get 12, I got to get repeat 12, I got to transmit, I got to call a STEMI alert to the hospital. I give nitro or fentanyl possibly. I got to take a look at this, take a look at that. And now we're like 10 minutes down the road and the patient may be like completely lost in what's going on. And I'm not just talking about STEMI, I'm talking about any call, especially the ones that have a lot going on. And then that's your point. And you don't have to say this at the end. You can ask this throughout your interaction, because it's not just like a finality type thing. It's a conversation, just like Cody led off with. Like, this is a conversation. This is not an interview. So constantly have this back and forth between you and the patient. And if you're not telling them what you're doing, be like, hey, do you have any questions about what's going on? Do you have any questions about what I've done or anything like that? If you haven't already asked them or had that look on their face like, what is going on? I need all these answers. And then maybe you should start talking. But yeah, this is very vital. And I know when you posted originally, there was also some talk of this as an educator, how you finish off your presentation. I know I'm guilty of this. I say, do you have any questions? And this changed. I haven't presented since you posted this, but this will change how I cap off my presentations as an educator.
I find it makes a big difference in the classroom. I try to, when I pause between content or whatever, and I'll say questions. What questions do you have? And I just wait. And almost always, like, someone comes up with something versus, do you have any questions? They're just like, nope, let's go on. Come on, let's move. Let's go. So yeah, I think it's a fabulous tool in the classroom as well.
I'm going to adopt that.
I've taken an approach when I do presentations. I take the questions slide out completely. It is out, and I close my presentation out with, guys, I'll be in the back for those of you guys that got questions, and I'll be standing right by the door.
Yeah, that's good too, because then it gives people the opportunity to ask questions that maybe they're not comfortable with asking in front of other people. And like in your world, you do a lot of conferences and stuff, right? So like people are in a room with strangers, so they're not going to be as comfortable just asking versus like if I'm in a room with paramedic students that have been with each other for the last year, then they're a little more comfy asking those questions. So just again, reading your room and figuring out what's going to make the most sense for your audience, whether it's a patient family or a classroom of students.
That's key if they give you the hangover slot, which is the first thing the next morning after a big party night. It's key. It's key.
No, I really like this. I'm going to change my practice by saying what questions you have, because I think I always say, do you have any questions for me? I like, now that I'm thinking about it, I wonder if I sometimes say, what questions do you have for me? I honestly haven't paid attention. But no, I definitely am going to try to make a deliberate effort to change that, because that makes sense. I see where you're coming from with that. I'm just going to comment. Cody's really good about staying after for questions for all his little fans that hang out and want to talk to him after. So I've witnessed that. I've witnessed the Cody Winniford effect. So, all right, where are we at? Next, number 5.
Yeah,
right?
I think we really only have one more that we haven't talked about yet, which is the infamous calm down. So I hope that we all agree on this. And yet it's still done. We have the patient that is worked up. We have the patient that maybe is having an anxiety attack. The patient that is tachypnic because of a medical emergency, whatever the reason may be, but like telling any patient to calm down is just like not helpful at all ever. It doesn't work on your girlfriend. It doesn't work on your patients. Right. So, I just think that's something we need to remove from our vocabulary. We talked about not having good training for death notifications. We really also don't have good training for dealing with, like highly emotional states like anxiety,
acute crisis.
Yeah. I mean, psych is in itself is a whole different like ball game that we have piss poor training in. But even just the basics like anxiety, right? We don't know like what to do, and everyone has these different methods. And some people like make people count and make people breathe certain ways and all these like fancy things and whatever. And maybe some of them work, maybe some of them don't. My preference is to explain to the patient exactly what's going on, let them know that they are safe and they are well, that their vital signs look really good, that I recognize that they feel terrible, but I want them to understand that there is nothing alarming about their presentation at the moment. If they're feeling like carpal pedal spasms or something, I'll explain to them why they're feeling that. And then beyond that, I like to just have distracting conversation. And in my practice, I have found that that works. I know other people have things that work for them as well, and that is perfectly fine. But what does not work is telling patients to calm down.
The big thing for me is positioning and like body language, right? So if I'm 5'11" and I'm like 260, right? If I'm looking down on someone whether we just, Narcan them and they just woke up, or someone's having a psychiatric crisis or whatever, I recognize that I'm an imposing figure, and if I don't get down on their level, it's not going to help a situation at all, right? So that's number one. The big thing that I had to do this a few weeks ago for a suicidal patient who wanted to have nothing to do with me, and all I did was I got down on their level and I said, "Hey, I know this sucks. Talk to me. What's going on?" And just that little bit, the patient just switched their affect. Everyone before then, including the bajillion law enforcement officers, were treating this patient like, kind of like garbage, right? Not necessarily on purpose, but that's just cops are doing cop stuff, right? The folks that, from the EMS perspective, were all standing around the seated patient with like one of them had a clipboard. And I was like, listen, just get out of the way. Let me sit next. And I physically sat on the couch with them. And that made all the difference. So, this is a huge thing for me because I get so irritated when it's almost like what John Moon was talking about with like walking in with that big flashlight, right? Like it's just I can't stand that affect. Like we're not there to be law enforcement. We're not there to like be antagonistic. We're here to help them out. Try to get on their level and just I think of it, the word indirect comes to mind, and that's not maybe the best word to use, but don't be antagonistic. Don't be the word will come back to me. But yeah, that's my 2 cents on that.
Go ahead, Josh.
So I find this to be a very divisive topic in providers and clinicians because now I'm not talking about like the calm down portion. The calm down portion is 100% on point that you don't use those words. My wife yelled at me long ago about using those words when she's mad at me or mad about something, and that obviously does not work, and it doesn't work for anybody else. Just like Lindsey said, doesn't work for your girlfriend, doesn't work for your patient either. But the way providers approach these situations, there's a lot of like callousness and saltiness about dealing with panic attacks and anxiety, and we can all have our own thoughts about it before and after the call, but not during. During it, we need to be on the level with the patient, whether that means physically sitting down with them, getting down to their level, not crossing your arms, not being standoffish, not standing over them. Have a conversation, talk to them, ask them, what made this happen? Okay, let's talk about it. Tell me how you feel about it. And, try and identify with them and like try and figure out what is going to make the situation that you're sitting in right there best. I remember this, I think she was 14 years old. She was in the car with her mom. Mom said something that set her off, and she yelled and screamed, basically threw herself out of the car in this court. Luckily, they were going like 5 miles an hour, and then just laid on the ground and had a panic attack. Looked like the way she was breathing and moving looked like a seizure from afar. She was just full blown into this panic attack and having this situation about what happened. Got her in the back of the unit, away from everybody. Mom was there, and we just had a conversation. What happened? Okay. And, are you okay with mom being here right now? Okay. And just talk. Never said calm down. Maybe do a little coaching of breathing. Like, let's do some in through the nose, out through the mouth, little box breathing type stuff. And just try and bring a calming presence to the scene. Because they may not be the only person that is having a panic attack or having an emotional event. The family may be adding to this whole thing. Like, hey, let's get out of the apartment. Let's go to the unit. We don't have to go to the hospital, but let's just go have a conversation. But back to what I said, I think it's a divisive topic in clinicians that they go into it with a very salty opinion of how this is going to go. It then turns into how they handle the call, and it doesn't really make things better. Sometimes they end in bad refusals, bad downgrades, bad transports, or no transport at all. And then just it doesn't work out for everybody. And I can't think of who I was listening to recently, but they talked about or maybe it was us. I don't know. I'm confused right now. But talking about how, it was us. It was with John, not John Moon, Brashears. We were talking about we don't know what's going on with these patients. We don't know what's happening. We're the first contact with medicine that they are receiving. And we need to make that a good experience and not be an abrasive experience.
Those salty. Oh, go ahead.
No, Lindsey, please.
I was just going to say those salty providers are the same ones that write off the anxiety attack that ends up being a pulmonary embolism, right? The patient codes in the ER. And even beyond that, when we are doing these truly low acuity calls, I feel like that could be an episode of its own. I just don't understand the motivation behind people treating these patients poorly we have absolutely, in our brief interactions with these patients, whether they're a frequent flyer or not, we have no idea what they've been through in their life. We don't know what their childhood was like, what their early adulthood was like, depending where they are in their life, right? We don't know what their family life has been like, what conditions they were raised in, what challenges they're facing now. Like, we do not have enough information to be judging these patients. Not that it's our place anyway, but like, to pretend like we know enough about these patients to make a judgment is like absolutely asinine to me. And there's just simply no reason to be treating patients like this.
That's
And
your next reel. That's your next reel right there.
And patients and babies and puppies are all the same when it comes to the fact that they all feed off the energy around them, right? Like, when kids are around stressed adults, kids are stressed. When dogs are around stressed adults, dogs are stressed. When patients are around stressed adults, patients are stressed. And if we can just be the calm in the storm, like both Moose and Josh just said, like, just bring it down a notch, be a human fucking being, like, stop, put the clipboard away, put the tough book away, like, just talk to the patient as a human being. Like, that is the best thing we can do in so many of these situations.
Yeah, I would really echo what both you just said, and I really do take it very personally. I've been very open on the show about my psych issues, and watching people talk to psych patients like they are borderline subhuman for no reason other than the fact that they're delusional, suicidal, in psychosis, whatever it is, that it's beyond frustrating, and I don't understand the motivation behind it. I think part of it is fear and misunderstanding, and just feeling of superiority. I don't know. I don't know what causes people to act like this, but I've seen it from medical professionals, from law enforcement professionals, from anybody you can imagine. Just this poor attitude, this salty attitude that you're describing. And I don't understand it. It frustrates the hell out of me every time. And I always stay professional, and I step in and correct it. And I feel like it has gotten better over the past 15, 20 years, but it's definitely still a problem in some places.
It's huge because we're too connected to, we're so attached to our emotions in those situations. You guys have been saying it for a minute now. Calm is contagious. Model the behavior that you want to see out of everybody else, right? Like, be that true north in a chaotic situation that folks can look at and go, okay, this is what I'm supposed to be paying attention to. But first and foremost, you have to stay detached from your emotions in this whole thing. So if they're a waste of your time, this is nonsense. You got to get away from that shit. It is not about you in that situation. And then the next thing you have to do is, if you're going to detach from your emotions, you have to connect to theirs. Like, with simple statements like, look, man, if I was in your situation, I'd probably feel just like you do right now. And I would probably want to jump off this bridge too. But we're not going to do that, right? I'd be just as scared, just as frustrated. It's like, give them something to kind of like munch onto so that you guys can connect to each other, so that you can set the stage for what you have to do next. So I'm connected to you now. I look, man, I know you're scared. I know this sucks to be you right now, but hey, listen, this is what's got to happen next. And now you have to kind of set a little bit of an expectation for, hey, we're here now, and we're not going to let the situation escalate beyond this. So it's, hey, your job, your sole purpose for the rest of this transport is to, and give them a number, give them something to focus on, give them a job. Hey, look at that respiratory rate or their capnography. Say, hey, man, if that number goes above this, I want you to take 2 faster breaths or something like that. Like, just give them a job to do. Or if your heart rate goes over to this, I want you to take 6 big, full capacity breaths and start to kind of bring those numbers down. Again, not calm down. We're not gonna use those words. And if it's one of those emotionally charged events, like somebody's combative, you just have to say, hey, moving forward, I need things to stay cool and collected, right? And otherwise, it's going to pull us off of being able to take care of you as effectively, or your loved one as effectively as we need to. And that's definitely something we want to avoid, right? You want us to take care of you. You want us to take care of them. And we're going to do that. And this is how you can help. And you make them a part of the process.
Cody, you brought up 2 things. The end title thing. I just saw that on social media. It was like, why did I never think of this? Where you take an inline capnography and let them hold it and have them breathe through it, and then have them concentrate on the number on the screen. Let's keep it in this range. And sometimes that'll work. Sometimes it won't, but it's a tool. It's something to throw in your toolbox, exactly right. And then about the emotionally charged, almost combative patient that's verbally, physically combative with you. I had this girl, she was probably 20 years old. I don't know what happened in the house. Police were there. She was in custody. She was flopping on the floor, not cooperating with us. We ended up using a Reeves stretcher to get her out, fourth floor apartment. We got her in the unit. She was still yelling at me. She was trying to pull away from the restraints. She was yelling at the police. And, I pulled out the narcs just to have them there, just in case. And she saw that and she freaked out. She's like, no meds. And I said, okay, so we're going to have a conversation. I want you to not yell at me. You're not going to yell at the police. You're not going to try and hurt yourself or hurt me or hurt them. And we'll never use these medications. He said, are you going to pinky promise me? I said, sure. And I held up the pinky promised, and off we went, totally calm and collected the entire rest of the trip. We had a conversation. I asked her what was going on, bridged that into, what do you do for work? What do you like to do? What music do you like? What's your favorite movie? And that's kind of something I wanted to talk about. A distracting conversation doesn't only work in your emotionally charged patients. It works in a lot of your patients. So especially you're like borderline critical that are alert and oriented, but something's wrong, your STEMI alerts. If someone's got a heart attack going on and they're, relatively stable, but you got elevation or depression that indicates STEMI alert and you've done everything, talk to them. Distract them from what's going on, because it's going to help with their blood pressure, their heart rate, how they're feeling about everything, and just talk to them on the way to the hospital. With kids, what's your favorite subject in school? What's your favorite sports team? What's your favorite TV show? Morph that into adults. What do you do for work? Your elderly patients. When did you retire? What did you do for 40 years? What are your grandkids' names? What do they do? And just get their mind off of what's going on.
Cody had also mentioned like detaching yourself from the patient. And I think this is so important in situations that require de-escalation, because how many times have we seen patients who are agitated and they are insulting providers, being rude to providers, cursing a lot, and the provider gets like personally offended and gets defensive. And then that elevates the entire situation and it escalates and it snowballs. And like, I personally can't wrap my head around this. I'm like, why do we give a flying fuck about what the patient thinks about us? Like, you can call me the nastiest names in the book. I don't care. Like, we're not friends. We don't know each other. I'm not offended. I'm going to go on to the next call after this. Quite frankly, you can call me whatever you want as long as we get to the hospital in one piece. And I know that a lot of people will feel otherwise about this, because there's a lot of thoughts of, well, we deserve to be treated with respect and we don't deserve to be verbally assaulted and blah, blah, blah. Bro, we signed up to deal with people who are drunk, high, have psychiatric illnesses, and some of them are just fucking assholes. And like, that is just part of the job. And yes, I'm not saying that we should tolerate getting punched in the face by someone who is alert and oriented and not under any substance, any influence or whatever, right? Like, yes, there is a line, but to some degree, like, we have to have thick skin to do this job. And if you just detach yourself from the patient, you are a calm source of good vibes. You don't take things personally. You're just quiet. You diffuse the situation. That avoids so many of these situations. I feel like we all probably have known people in our careers that have repetitive issues with patients, that get into scuffles, that have these like encounters with patients. And then like, I think I've never had that because like, I don't care enough to get like defensive or worked up, like whatever. It's just not that hard to diffuse a situation and detach yourself, versus the people who take every little comment personally and get defensive, and they escalate these situations, and then it turns into needing like physical restraint or chemical restraint when it was totally unnecessary if the scene had just been handled correctly.
I think to that point, Lindsay, we really only get taught that de-escalation stuff in school, and most of us get into this job at 18, 19, 20 or so. And this is going to be a hot take a little bit, so I'm going to warn you guys ahead of time. Just like the police, they get tased and tear gas when they're in school, so they know how it feels and know that, hey, we really want to avoid this stuff if we can help it at all possible. We should all get punched in the face in paramedic school, because I think, to your point, Lindsay, that is a lot of the problem. No, I'm telling you, if some of these young kids are real quick to mouth back off at a patient, and he's like, bro, you're in the hood. You will get clapped up real quick in the hood. You cannot talk like that in the hood. You will get your nose broken. And because they don't know how that feels, so they don't know to avoid that situation at all costs. So it's like using that verbal judo before you find out that the other person actually knows judo, and you get your butt kicked on the street. I'm telling you, we should all get punched in the face or slapped in the face in paramedic school, so we know, hey, no, let's de-escalate, because I didn't like that feeling.
Cody earned his reel. Cody just earned it that reel. That's gonna be perfect.
That was spicy.
A little spicy.
And a little bit of a serious note on that. There's a book out there. I think, Lindsay, you've shared it. Someone did Verbal Judo. It was part of our most recent leadership, not leadership, our study material for our last promotional exam at work. Like, that's a book that probably should be in the curriculum for most, at least paramedic programs, or something of that sort, because we talked about it. I want to say during the social work episode, actually, with Jasmine, that there is I don't know of any program that teaches de-escalation, especially in paramedics. That day I said, I've been through two EMT courses, one paramedic course, teaching it. I've been through an academy. Never once have we talked about de-escalation.
It's called the School of Hard Knocks for a reason.
I did not share that one, Josh, but I have heard of that book, and people have recommended it to me. And I'm actually glad that you mentioned that, because I really need to order it and read it. The one that I just shared was The Body Keeps the Score, which I think is also really relevant to this conversation, because I think that it helps develop like a lot of empathy and understanding for like what people go through. And it just talks about a lot of individual patients and groups of patients who present with these really extreme behavioral symptoms, trauma symptoms. They're things that we see every single day. And these are the same patients that some providers get annoyed with and sassy with and short with and impatient with. But this book really kind of opens up your eyes to the things that patient very well could have been through in their life that is really freaking terrible, that we need to be empathetic to and understanding of.
I got another hot take for you. Do you guys could back me up on this one or not, that do you believe that if we had better de-escalation training, that there would be a lot less violence against EMS folks?
Oh yeah,
out there on the street?
Yes.
Because I bet we would see a drop in chemical sedation as well.
Oh,
yeah.
100%, right? So you see the headlines, they're everywhere. It's EMS, you're 99%, more likely to get punched in the face at work than EMS. I'm like, well, not if you're not an asshole.
Yeah.
When I see these headlines, I'm like, yep. I know you get punched in the face. I'm like, you're one of those statistics that you walked into rooms with, what'd you take? Caught one right in the mouth for it. I'm like, just treat people like it, all joking aside, there are people out there in the universe that will not hesitate to show you that your attitude and your uniform will protect you from exactly nothing. And you need to go into those rooms and go into these houses and schools or wherever we're operating with that at the forefront of your mind, and figure out a way to keep from getting into a physical altercation, because it's not just getting punched in the face. There's legal ramifications for everything that comes after that. So just be a good dude. It's not that hard.
Yeah, and swallow your pride. There's so much ego. Like there's no place for ego in this. You know, the dudes that get offended by being insulted by another dude, like, dude, let it go, right?
Yeah. Now somebody's going to hit us in the comments and go, hey, Cody, I remember that time we were at XYZ and you, yeah, I'm like, yeah, that, you learned the hard way.
Josh, were you going to say something?
I was just saying, body keeps the score. I feel like Moose or Ken, you guys talked about that before.
I feel like Ken did, right?
I haven't read it, but I have been recommended to read it by multiple people, and I've heard a lot of good things about it. So I can't comment too much on it, to be honest.
And Lindsey, you were saying to get verbal judo. You commenting on how long your commute is. I think from what I heard, it's a very short book on tape. That's what one of my coworkers did with it. He listened to it on his commute because he's got like an hour and a half commute.
But is it less than an hour? Because I don't know that I can pay attention to a single.
Now, so Lindsey is not going to listen to this episode because she's going to Space Cadet on it.
I listened to our last one with Warner on 2 times speed, so I got through it.
You know, thinking about, I've been thinking a lot about what you guys have been saying, and obviously this doesn't account for everyone, because certainly there are assholes that are paramedics and EMTs. That being said, hurt people, right? I remember being in a very bad place mentally, and that directly correlated to how shittily I treated some people. And I remember those, right? So I think when you guys ask, why do people treat people this way? It's, it's easy to treat someone nicely. I think it's important to remember, and maybe I'm off base here, man, but I have never seen a new EMT or a new paramedic come in and be an asshole, like in this perspective, right? Like, yes, we all know there are assholes out there, but I'm a big believer in, if you are seeing coworkers act this way, come at them with the same compassion that you would with a patient, right? And try to have the same things we just talked about, get to their level, try to have a conversation, distract them, and try to get to why they're doing what they're doing. It's not as simple as saying, why are you being an asshole, right? Or talking behind their back and saying, why is this person always an asshole with addicts or whatever, right? It's important to understand, it's important to remember that they're also a human being. And one of the things that came up in my head is, what is the definition of salt, right? We say someone is salty. The first thing that comes to, not the first thing, but one of the things that came to my mind as I was listening to you guys, it's a culmination of emotional trauma that just jades someone, right? To whether it jades them to be, I don't know, falsely overconfident or just overly rude towards particular patients. To me, it's a culmination of emotional trauma that is leading them to treat people this way. The last thing I'll say is, with my therapist, now over a year, we've been working on this concept called shadow work. So the general idea is the outward affect of people, in a negative way. So if they are outwardly criticizing someone for being, I don't know, too cocky or whatever, a lot of times it's a reflection of their own perceived inadequacies. So they're trying to project a perceived fallacy that they have. How does this connect to what we've been talking about here? I wonder if there's a connection between folks that say don't have a good affect with certain patients and their own internal, mental health and lack of confidence or whatever that may be. And I'm not doing too good of a job of eloquently saying this, but I don't think it's as simple as treat people better, because we are constantly under attack, and especially certain folks in certain jurisdictions get their asses handed to them 24/7. And I think if you're in survival mode, you don't have time to do that metacognition work of, hey, why am I treating this patient this way? So I know that was a lot, but I just wanted to throw that out there, that the same compassion that we're telling people to feel for their patients, we have to have that compassion for our coworkers too.
I think you're spot on, Moose, is that in any personal interaction or in any of those calls that we're talking about, there's who I am right now and who I need to be successful in the situation. And in that gap is your own selfishness, weakness, and fear. And that's what you're attacking them based on one of those three things. I think you're spot on with that.
I agree with you as well, completely. And I think a lot of this comes down to reducing the stigma of mental health, talking about going to therapy, talking about dealing with these like demons that we have all dealt with at some point in our career. My caveat to this is that we are choosing to be in a profession where we have to be accountable for our actions. And so while I agree completely that someone may be treating patients like shit because they have emotional trauma that they have not dealt with, and I do think we should check in on those people and give them the resources to deal with it, ultimately, it is our individual responsibility to make sure we are doing this job well, and recognizing that if we are at a spot and we are too burnt out to treat people with at least basic respect, I'm not talking about going above and beyond, but like basic respect, then we need to make some big changes. I think you can equate this to physical health as well, right? Like I've been accused of having like double standards on social media about this, and I do, and I will stand by that all day, every day. Our patients who are morbidly obese deserve all the respect in the world from us. They deserve to not be treated differently, and they deserve to be treated like human beings. So do our coworkers, except it is not okay to be in this job and be unfit for duty, to be able to come to work and not be able to perform, to leave all of the duties to your partner who is more fit because you can't physically do it. So yes, we should be treating patients who are physically unfit with respect. I'm not saying to disrespect coworkers who are not fit, but it's not okay to be unfit in this job because our job requires it. And I think the same thing applies to mental health. Yes, we need to do a lot of work on decreasing the stigma, increasing the amount of resources, giving people an avenue to like fix things for themselves. But at the end of the day, we have to be accountable for ourselves and our actions towards our patients and our coworkers in our job.
Yeah, no, I certainly agree with you. I think the accountability. Marcus Parks is one of the hosts for the last podcast on the left, and he said something a while ago that has stuck with me, that mental health is not your fault, but it is your responsibility.
Yeah.
Right. And we've talked about that a couple times on the show here. I will say it's not black or white, though. Right. So, like I said before, when you are in that survival mode, right, when you are, and I'm thinking of a couple people, you're coming off of 24 and you're going on another 24 at another job because you have to, for whatever reason, you got into some bad financial times, right? And I'm just thinking of an example. It is absolutely. I don't think of it as a black and white thing. I think it as a not a spectrum. I don't know. I agree with you, Lindsey. I'm 1000% with you. At the end of the day, we need to deliver adequate and appropriate patient care, and we need to not be assholes, and we need to be polite with our patients when we do it. That's let's set the level there. I just think that when we dive into why people are doing it, I think it's a lot more nuanced.
Oh, yeah. I agree
It's
completely.
nuanced.
Yeah.
But
Like,
sorry, Josh, go ahead.
Go ahead. I'm sure what we're about to say is somewhat similar.
Okay.
So go ahead.
I was just going to say it is nuanced, but there are some very fine lines there, because I've seen people with these attitudes who will literally completely write off anything someone has to say because they have a history of bipolar disorder or schizophrenia. And that's not okay. I don't care what you've been through in life. You can't write somebody off completely because they've got a history of that. It's no different than writing off somebody because of their gender or their race or something like that. And I don't think that's acceptable. And I think it needs to be very clearly put out there that no amount of personal issues make it okay to behave like that, regardless of what you've been through. You have a responsibility to treat people with compassion, with equality and equity, and to be a responsible person. Because at the end of the day, if you're coming off 124 and going on to another, I'm really sorry about whatever your financial situation is, but that's not okay. That's not safe. You're not doing your patients any favors. You're not doing yourself any favors. You're probably going to crash and die somewhere. Like, this is a terrible idea. And I would be horrified if I found out that my paramedic was on a 48 somewhere and I was in the back of the ambulance and they were doing drug dosing on me or my kid. Oh, hell no. That's not going to fly. That's my
Or the person
2 cents.
driving lights and sirens.
Or the person driving lights and
yeah,
sirens. Yeah.
No, I'm with you, man. No, I'm with you, buddy. I get it.
You're going to get a lot of comments from the people that work 48s regularly. I know at my old job that was that was super normal. But I think it, of course, depends on like your volume and stuff, right? So like if you're putting yourself in an unsafe situation, then, you know, you have to take responsibility for that.
So two things. One, now I don't know that this is concrete, but I do know part of our whole QA process within my agency is when there is, you know, issue after issue with providers, meaning like a singular provider with multiple issues that are getting reported up for whatever reason. Our QA process involves, hey, we're not just going to talk about what's going on the calls. What else is going on? Like, what's going on outside of work? You know, what mental health issues are there? And they try and figure out a work improvement plan of some sort that helps to address that as well. Like, hey, do we need to bring in the employment
EAP?
EAP. Do we need to do EAP plan as well? What else is going on? Stuff like that. So it's not just like, hey, this is a singular your performance on calls issue. Maybe there's other stuff that's going on that's driving this. So that talks to that how we need to own our own mental health stuff and address it appropriately so that we can then appropriately address our patients and work with our patients. And, you know, on that whole 48 thing, so you know, I work for a department that's 24-hour shifts. It's not uncommon for people to work 48s. I used to do it, and I'm glad I don't do it anymore. I don't think it really affected how I was mentally, as in like changing my attitude towards patients, but it also just was physically depriving of like energy. But I did have a worker who specifically refers to that period in their life as their bad period, when they were working 48s every single set of 2 days for a year or two straight. And they'll look back on that and be like, yeah, I was not in a good space mentally, physically, how I handled calls. And they identified and they rectified in a way and have tried to improve themselves since then and have done that as well. So it's.
Do you guys? Sorry, I didn't want to cut you off, Josh. You have a good thread there. But do you guys believe that the organization itself holds some of the weight for the mental health piece of it, the fatigue management piece of it? I personally do. I believe that if you are having an individual with performance issues, or you're looking at your organization as a whole and going, man, we are missing it on XYZ metric, and instead of looking for individuals, that organization needs to look into its system and go, where are we inducing the error? Where are we, you know, sacrificing quality for quantity of units on the street, or quantity of houses open and hours in service and things like that? Organizations have got to take a piece of ownership of that. And, you know, like our organization, we use a just culture method for looking into human performance issues and seeing where, number one, did the system induce the problem? And if the system induced the problem, then the individual may not be necessarily off the hook completely, but it's definitely not going to be a disciplinary or shouldn't be a disciplinary outcome. for the individual, so that then the organization has to look back and go, okay, we've got to change our processes. Maybe we have to change our thinking. Maybe, just maybe, here comes another hot take, get ready for it. Just maybe pre-hospital fire departments will get off this 24-hour shifts crap. It's awful. I say
Love
that
my
working on,
24s. Don't take them.
no, they are absolutely horrible for the human body. And I mean, you can condition yourself to do anything, but doing that for 20 years, I've seen it too many times. It wrecks who you are
So
to be on duty like that.
I will counter you on the 24s. I personally enjoy my 24-hour shift. Hopefully, we're going away from the current one and going to a better 24-hour style without alluding to too much. But is it also dependent on the type of department? So like a 24-hour department or a 24-hour shift, and in a system where there is not a lot of room for promotion. So now you're stuck as that street medic for 20, 30 years doing 24-hour shifts. Or maybe there's an ability to promote and go into some lateral positions to get a break from the field, and stuff like that. And there's departments that, have that in some ways and other ways not. I can think of one in the Baltimore metro area that there's a lot of room for promotion on the fire side of the house, but not a lot of room for promotion on the EMS side of the house. And so those people are stuck in the medic unit for years. And, it is taxing. Being a street provider is taxing for those 24 hours. So that's
I'll walk it back a little bit, and
24s.
I'll concede that if an organization manages the 24 hours well, then the risk to the individual can be reduced, and the risk to the patients can be reduced, and the risk to the outcome can be reduced. I can concede that much of it. But there is a tax that no matter what your op tempo is, there is a tax that you as the individual will pay the next day for being on alert for 24 hours, for being in that headspace for 24 hours. There is a tax, regardless of your easy day. No, didn't spin a rotor in our cases, or you just got the shit beat out of you for 24 hours. The tax is just heavier. The more the heavier your op tempo is. But
we've by the way, we've gone into a massive rabbit hole.
I know, right?
But I find during the day, if I'm not busy, I'm more tired. Actually, because I'm used to a busy station, and if I go somewhere that's not busy, I am more tired. It's weird, but that's a personal thing.
But is it healthy?
I've heard from other providers.
I feel like this is a whole different, whole topic on its own. Cause for me, my commute is an hour and 15. So if I did 12s multiple days in a row, that's hours and hours of extra driving. And that for me kills my work-life balance and whatever. But going back to your original question of does the organization carry responsibility? Absolutely, yes. And in an ideal world, every agency and department would work I think our program does a very good job of this, of kind of trying to look and see, is there a systemic issue? But I think it's a slippery slope because too many people end up just blaming their organization and their department for their issues and not making changes on their own, when they could be living a fitter, healthier lifestyle. They could be changing jobs, going to a different department. Social media is filled with people bitching and moaning about their departments. But I've done a couple posts of asking people who are happy with their jobs to give characteristics of that, or even name departments. There's actually a lot of really happy people out there. There's a lot of really happy people in their fire EMS jobs. Believe it or not, social media is a lie when it says that everyone's fucking miserable at their job, And so if you're miserable at one department and it's running you into the ground, then maybe we need to consider going somewhere else, or setting ourselves up in a way that we don't have to work overtime every other shift or whatever it may be. Right. So I just think it's a really slippery slope. And at the very least, we have to focus on what we can take responsibility for and what we can change.
There's onus on both parties.
Yep.
I think it's a liberating thought too, right? If you keep thinking that it's a organizational issue, it's almost, I imagine it leads to a feeling of helplessness, right?
That's a victim mentality.
Yeah,
Absolutely.
and
Absolutely.
I'm not a huge fan of that. I'm a huge fan of taking ownership, right? And even if it's bite-sized amounts, recognize a problem, recognize an issue, and take steps to improve it, right? I've said this before on the podcast. Things are the way they are because people just like us made them that way. That's empowering because that allows us to be the change that we want to see, right? And if you're constantly just blaming the department or your whatever your reality is, you're not taking the time to see, hey, what can I do to improve this situation for not only me but the person that comes after me.
Yep.
I think it's super important. All right, so I think we covered all your points, right?
Yeah. What are you even going to title this episode? Like,
So I was actually thinking, like, a lot of this is like EMS communication, right? So like, or like EMS communication. I do have one thing that I want to bring up. How do you guys deal with language barriers?
I wanted to say something about this without like kind of going into a niche. So okay, my first due has a lot of Hispanics. And luckily I've had formal Spanish education, but I still find myself, I can't do conversational Spanish, but I've gotten really good at medical Spanish. But there's still things like, how do you describe pain? Like, I can't remember. I have to get better at it, but I have to remember, how do you ask, is it stabbing? Like, how do you just, like, ask someone to describe a pain? Because they may describe it in a way that you're not going to understand, even with your formal training in that language. Because while there's a lot of Hispanics, it's all Central American, El Salvadorian, Guatemalan, Honduran, from Belize, all over. Not so much from Mexico, which is the Spanish I'm used to. So they might use a word to describe the pain that, like, okay, I'm lost now. And then just technically, Google Translate is a great resource to use, as long as you can figure out what language.
You guys have language line through dispatch?
I know I do. Ken, Moose.
So every 911 center in the state of Maryland is legally obligated to have a language line for their calls, where the operation gets a little mucky when it's for pre-hospital responder use. Most places have it. So the reason I bring this up is we just had a protocol passed that I worked on, that I wrote with a colleague from the Baltimore City Fire Department and a colleague from one of our local Baltimore City hospitals, that will now, if passed by the EMS board, will compel EMS clinicians to utilize a language line or a sufficient surrogate that has been approved by their jurisdiction if a perceived language barrier is present. To answer your question, yes, with an asterisk, right? At least in Maryland.
My volunteer organization that is actually super busy. I've been there for most of my adult life. We have utilized language line really efficiently for my entire 15 plus years there. So I mean, it is a very seamless, you just call dispatch. Hey, I need language line. You let them know what language it is and they connect you and you put your phone on speakerphone and then you have your whole conversation and it is pretty straightforward. I've only had one incident that I can remember where there was no translator available because it was like some incredibly obscure language, like some subset of Ethiopia, like some language that like very obscure. That they couldn't find a translator and that was difficult. But otherwise, I mean, the area that agency is in, I think the schools there have like 60 plus different languages. It's an incredibly diverse area. And we regularly use language line there. And I've found that it's a really effective tool.
Yeah,
One thing,
we have it on our unit phones. We
Mhm.
have an automatic, like, the code is already input into the number, so we don't have to know the code to access it for the department. We don't have to go through dispatch. Um, we don't use it a whole lot. We have the resource, but we don't use it a whole lot. I think we use Google Translate more, honestly. But the one time I remember using it, it didn't work out for us because a lady was speaking a Chinese dialect. We got Mandarin first. The translator said, "Oh, that's Cantonese." Got us Cantonese interpreter, and then he just said, "Well, she's yelling too loudly and too fast for me to understand,"
Mhm.
and was of no help. A bad experience, yes, but I've heard some great experiences. My one hang up with using a translator, and I encountered this a lot when I was out here in El Paso, when I didn't have such good grasp on Spanish, was it changes up how you do your assessment. So, like, I have my own way that I've developed over 16, 17 years of doing this. When you have to go through someone else to, like, actually make it an interview and not so much a conversation, it kind of throws you off a little bit. And I encounter that a lot out here. Luckily, I got a little bit better. So in my current jurisdiction, I'm much better with it. But it's more of like, hey, now I'm going to follow sample and OPQRST to the letter because I have to tell someone else to ask this question of the patient to get a question answered back, and it's a back and forth. So I'm not a huge fan of using translators because of that, but I also understand that they have their very much appointed time and place.
Yeah,
I
you
was just going
definitely have.
to
Sorry, go ahead.
go for it, Lindsay. No, it's your turn.
No,
Go for
all I
it.
was going to say is that you definitely have to prioritize and like whittle down your assessment with translators for sure. It certainly can't be as robust as normal.
Yeah, there's two things that I've seen that worked really, really well, and you guys have probably seen this too, is if you speak English really loud and slowly in their face, they all of a sudden can understand English. And then number two, if you take your run form and you turn it upside down and you write in English, that they can read that too. So just a couple of tips for you guys out there that have language barrier problem. Just say
And
it
then
real
tell them
loud
to
and
calm
slow.
down. Tell them to calm down after.
Yeah.
Cody, a lot of our younger, newer listeners, like newer to EMS, are going to ask, "What is this run form you speak of?"
Oh, that's right. That's right. Man,
Yeah, we all
silly
just
me.
dated ourselves. Moose, did you ever use
Thanks,
an email
Josh.
form?
Thanks.
I only caught a bit of that, buddy. What'd you say?
Did you ever use an emails form on an
No.
actual call?
No, not at all. Not at all.
And,
Do you even know what the big
well,
metal clipboard? Have you
Oh,
seen
trust
one?
me, you should see the boxes of them that I have in my office. I have a case of the EMA's narrative edition in my office, like just sitting there because I just think it's cool.
so, Lindsay, this brings up a great thing. Remember the old OEMS forms that had the narrative box that was like 4 sentences?
It's okay, Josh. Just fill out the addendum. There was an addendum form. It's okay. You got all day to write your novel.
I hated those things. God. Oh.
Hey, real quick, just going back to the language line thing. So, yeah, there certainly is a time and place. I'll push back a little bit on the Google Translate thing. I mean, I feel like if you don't have anything else, then sure, use it. And of course, I don't have the references to back it up, but when we were doing the work, there were some like significant negative outcomes that were brought up. I'll have to add it to the end of the episode or something, but if it's all you have, it's all you have, right? But it's certainly better than nothing. This kind of goes on to like a cultural sensitivity talk too, but this kind of goes hand in hand with if a woman asks for a woman provider, right? Or a male asks for a male provider. Sure, you have to function within the constraints of the system you're in, but don't dismiss those people either, right? So my mom, so I'm Muslim, right? My mom wears a hijab. She would prefer a female attendant if she's able to, right? And certain invasive things or even like EKGs or something, she's just not going to let a male do. And that's the reality of it. And you got to respect that. And I think unfortunately, a lot of folks don't get that in fire and EMS, and that's one of my big sticking points with folks when I see that happen in front of me. The other thing is, it's interesting you brought up like that super specialized language, right? Or what a rare language. My mother language, English is my second language. The first language I learned is a super rare dialect of Gujarati, which is an Indian language. And it's kind of nice not being able to find translators because you're pretty confident that no one's going to understand you in public when you start like cussing them out or something. But it kind of it sucks when you actually have medical emergencies, right? Now, to that point, it is not okay to just not do an assessment because there's a language barrier, and I think we all agree with that. But I want to say that because I've seen it happen where people will just ignore doing an assessment because there's a barrier, and then pertinent information is ignored, and then ultimately the patient gets transported to an inappropriate destination, right? So I just want to stress that while we're talking about this, is take that extra step, of course, with within reason, and try to communicate with your patients. And I want to get your thoughts on so the strict medical thing that I've learned is do not use family members for translation. What I would say is this. Obviously there's a ton of different variables here, but if I have I'm thinking of one patient in particular, again, I had a couple months ago, very sick. I need communication with this person. I could understand bits and pieces of this particular patient because I understood the language that they were speaking, but I'm not fluent in that language. And in that instance, I ended up using the patient's family member to help me because it was a crisis. I did not have time to get language line and mess with them. And we needed to get this patient to the hospital for a time-constrained illness. So I just want to get your thoughts on that and how you've handled those situations in the past, and what your thoughts are on family being used for limited translation.
I have no issues using family whatsoever. I mean, unless there was like, some concern of like domestic issues, like that aside, I would way rather use a family member than someone through a phone, like 100% of the time.
I find myself using the children, the sons and daughters a lot, because they'll know the Spanish or English, or because of school. So they're learning it at school, and they are a pretty plentiful resource. And I agree with Lindsey. I'd prefer to use them instead of a phone. I also understand the trepidation because the family member may not be as forthcoming with with the other family member, and in turn, that family member may withhold information, either the translator or the translatee. It's just I understand it, but I also understand that at times, taking the phone out, getting the interpreter, it's not always a quick process. So using that family member may be just what's most convenient. We live in a world of gray in this job, and we can't always just stick to always using language line or never using it. We got to find out what works best in that moment for us.
Yeah, I've always had pretty good success using family members, with one exception. I won't give the whole story here. It was a very sketchy situation where I don't think the family member we were talking to had the best interest of the patient in mind. We can talk about that offline, but I do think there is reason for caution when using families because you don't know what the situation really is, and there could be something untoward going on.
Yeah, I can't stress enough. Use the language line unless you have to use the family member. I can't stress that enough. I've both from being someone that knows a lot of different cultural things are different with different cultures, right? Something that I've also experienced personally in my own family. That coupled with what's medically appropriate, use the language line unless you absolutely can.
Cool.
Lindsey, did I cut you off?
No, it's okay.
All right.
I just
Cody?
I just don't totally agree.
Sure, go ahead.
And it's I don't know. I don't want to like kick a dead horse, which is why I didn't say anything. But I just think a lot of it's reading the room. I think we run a lot of really straightforward calls. Like people are unwell, people have medical emergencies, they have new chest pain, they have injuries. And like, I think it is easy. I know that certainly different cultures can make this harder to read the room because we don't know what the normal vibe is of a certain culture in a household. But I would say that the majority of our calls, I feel like we are capable of feeling like, okay, this is fairly straightforward. I just need the basics of this. But then, if we feel that something is off, if there's any potential for any sort of manipulation or whatever it may be, then that's when we would go to language line. But I just feel like language line can be so impersonal and can be so technologically a pain in the butt as far as just like, can you hear correctly? Like, relaying to them, relaying back and forth over the phone. It's just a pain in the butt. So, and I don't know, maybe I'm wrong in that. Like maybe I've gotten misinformation more than I've realized during my career. And that's certainly a possibility that I need to consider. But
yeah, I mean, I can see where you're coming from. The issue is you only have the perspective of your own background, right? So
Yeah.
what you might not perceive as an issue may be an issue just because there's no way for you, because you haven't lived that experience, right?
Yeah.
That's why I certainly the in-hospital community agrees with what I'm saying, where use a medical translation service when possible, because like you said, 90% of the time our stuff is pretty clear cut, right? But the issue is we don't know what the 1% is.
Yeah.
Right. And no clinician knows when the 1% is. And especially when it's male-female dynamics in certain cultures, you have to use a resource that is not tied to the patient in any way, because I've seen people even want to refuse care for another family member, and we're like, yeah, no, that's not how this works.
Yeah.
And we need to hear it from that individual. And I've gotten law enforcement involved as well. So certainly just because it's a tedious technological issue, and I'm not saying you're saying this, but just because it's tedious technologically is not an excuse to not utilize this, because and I know we all agree on this, those patients deserve the same treatment that every other patient deserves, right? So I agree with you to a point, but I stand by what I say.
No, I think it's
that, like, hey, yes, you got to take into the consideration cultural sensitivities. That sometimes is a big brain thing, like to understand what's going on. Not to insult anyone, but like some people just don't understand it, and some people don't want to understand it. So that is a big brain thing at times. But I also want to add in, like, I'm going to come from the same side as Lindsey, that I'm going to use the family member. I'm going to use what's available to me. I know there's language line, but it's just what I'm used to. Also, we need to take into consideration our actual assessment, not just our talking to the patient. Like, if what the information that you're getting from the family member does not line up with everything else you're seeing. So, like, you're talking to a family member, said, do they have any chest pain? Oh, no, but they're like grabbing their chest, or they've got, they're diaphoretic. They look like shit. They sound like shit. They are shit. But the story you're getting just doesn't jive. It's like, okay, I need to discredit everything that they're saying. And this goes for, by the way, English speakers too. This is not a language barrier thing. Poor historians transcends all languages and situations. So, like, take into consideration everything you're seeing. Like, if that family member it's not lining up, then okay, they can tell me whatever they want. I'm going to then institute things like language line, Google Translate. If it's Spanish, I'm going to do my best to fumble my way through my Spanish with them. And it's the same thing. Like, if the hospital all the time is in the ER, they'll try and find, at least in my area, a Spanish speaker before they go to language line for a patient. A Spanish-speaking tech, nurse, doc, a lot of docs in our area have become fluent in Spanish because of their patient population. So, like, I don't want what I'm trying to say is I don't want people to focus on, like, hey, our only tool in these patients is language line. No, we need to take everything into consideration. Your patient assessment can tell you a lot, regardless if the patient can talk to you in English, Spanish, French, Dari, Pashto, Korean, Russian, all the ones I've experienced in the past 3 weeks. And, or if they're unconscious. Remember, we have these tools. Let's use them appropriately. But
I was just about to say that we manage patients where we have zero information all the time. In my opinion, the subjective is going to be limited when there's a language barrier, but you still have the exact same objective assessment that you would do on an unconscious patient versus a conscious patient, and you should still be able to uncover the life threat as best you can, even if there is a language barrier.
I think
Josh is stealing my thunder.
Well, Moose, correct me if I'm wrong, but I think your point is a bit more, which I'm definitely rethinking this now a little bit, like after your comments, is no information is sometimes different than misinformation. And so like when we have no information, we're forced to fill in the blanks with what we think. But like if you're being fed misinformation, either intentionally or unintentionally from a family member, that can be a little bit more difficult to course correct. So, yeah, I definitely see both sides of this.
No, absolutely. And Josh, I love the points you made. Of course, right? Of course, this is part of a patient interview is part of a larger assessment. So that goes without saying that your patient interview should be one part of your whole assessment. No, I thanks for bringing that up, Lindsay. Yeah, that's exactly what I'm saying. We are patient advocates, and we should be trying our best to get the best information we can. And yeah, that's I think that's all I'm saying. Yeah.
Okay.
Trying to think of what else I was going to bring up, and I'm having a brain fart.
Finishing on some controversy.
That's
I
right.
like it.
Yeah, no, this is good. An hour and 45.
That's
Wow,
pretty good.
jeez.
I'm never going to make it through listening to this one. Never.
2 times speed, Lindsay. You got this.
That's my only hope.
What was I going to say? Lindsay, thank you so much for coming on again. I think this was another fruitful conversation. And Cody, thank you for joining us, man. This was good. I love the camo Maryland. I think it can be both.
It is camo. I told you.
Lindsay, you got any closing comments?
No, I think that was a great conversation. Lots of rabbit holes and tangents, but very fruitful. Thanks for having me.
So much real material for Josh. You have no idea. Cody, you got anything, bud?
No, man, I want to second what Lindsay said, man. Just thanks for having me on.
Cool. Ken, Josh, any last comments? And then you guys can fight over who can close us out.
I will.
Okay.
Thank you, everyone, for listening to Alert Medic 1. Please remember to leave us a like, a rating, or review. Check us out on social media. Let us know how we're doing. Thank you for listening. Thank you for watching. Check us out on YouTube if you're listening to this. Have a wonderful day, evening, night, whenever you are. Thank you from Alert Medic 1.
Nice.